Hello, everybody. Thank you for joining us on this webinar about the SCIMITAR bespoke smoking cessation for people with SMI webinar. My name is Ciaran Osborne. I'm the Director of Policy at ASH. Thank you so much for joining me. I'm hopeful that you can now see my screen. If I just minimize this. Hang on, sorry. Yeah, there we go. Okay. Sorry, I'm just moving this out of the way so you can read it. So this is a webinar provided by the Mental Health and Smoking Partnership. The partnership has been brought together to reduce the gap in smoking rates between people with a mental health condition and people without. We have a target, kind of an aspirational target of reducing the rate of smoking among people with mental health conditions to 5% by 2035, with an interim target of 35% by 2020. I think that's challenging, but one of the great things about the webinar today is that the SCIMITAR research shows some great ways of moving towards that target. So we're being joined today by Professor Simon Gilbody, who is the Director of Mental Health and Addictions Research at the University of York and was the lead researcher for the SCIMITAR trial, which looked at bespoke smoking cessation support for people with severe mental illness. Throughout the webinar, you'll have an opportunity to ask questions, which you can type into the box on the right-hand side of the screen. We'll collect those throughout the presentation, and then I will ask a few of them to our panel, which is Simon, Dr. Emily Peckham, who is the SCIMITAR trial manager, and Suzanne Crosland, who is a mental health nurse and one of the nurses involved in the trial. So at that point, I will hand over to Simon to get down to the interesting info.
Good afternoon, everyone. Ciaran, can I just check before we start that people can see my screen?
I can definitely see your screen, and John can see it as well. So I'm going to say that people can, but if people out there can't see it, then please do type in the question box, and we'll see if we can figure it out.
Very good. So, Ciaran, thank you very much for the introduction. My name's Simon Gilbody. I'm based at the University of York, and I led the SCIMITAR trial, which is what we'll speak about today. And I'm someone who's worked in NHS mental health services for around 30 years, and I've some experience of providing care to people with severe mental ill health. And I've also been able to witness some of the profound impacts of being a user of mental health services on people's physical health. And it's with this background, I, together with colleagues, for about 10 years have been working in the area of smoking and smoking cessation in mental health services. And I'm going to talk to the SCIMITAR trial, which is the culmination of about between 10 and 12 years work in this area, and we published the results of this trial just in the last couple of weeks. So we're very excited to be able to talk about the results of the SCIMITAR trial. I'm joined here by two of my colleagues I want to mention. So Dr. Emily Peckham is the person who helped deliver this trial. So also in the room is Suzanne Crosland, who is a very experienced mental health nurse and researcher, and who was involved in the delivery of the smoking cessation intervention in the SCIMITAR trial. And we as a panel will be able to answer some questions after I've given you an overview of our research. So thank you very much for your attention, and hold on to your seats. I'm now going to talk about SCIMITAR and the SCIMITAR trial. So I'm going to speak a little bit about smoking and severe mental ill health, and I'll talk about what we know about research in this area, and that provides some context to the SCIMITAR trial. And the SCIMITAR trial is the largest trial of a behavioural intervention for people who smoke and use mental health services, and it's a piece of work that we're very proud of. So I'm going to spend a few minutes talking about the history of this trial, how it came about, and how we thought about the design of this trial. I'll provide an overview of what I think are the main findings from this trial, and I'll give you some of our initial thoughts about what the implications of this research might be for mental health services and the formulation of policy in the area of smoking and smoking cessation, and also speak about how we hope to ensure that the results of this trial translate into changes in practice and policy, and how we might think about disseminating the results of this trial. So the first picture I'm going to show you is a graph, and it's a graph that represents what we call the mortality gap amongst people with severe mental ill health. Risk represents the fact that people with severe mental ill health experience some of the most profound health inequalities of any section of the population. And this is illustrated by this graph, which shows two tram lines running in parallel, one going upwards and one going downwards. And it shows the average life expectancy for men and women and how that's changed between 1980 and 2010. And there are two sets of lines going, the first going upwards, and that shows that the life expectancy of the population in general has been increasing year on year since 1980. And the other set of lines that you can see going in the opposite direction, going downwards, are the average life expectancy of people with the most severe forms of mental ill health, schizophrenia and bipolar disorder. And this graph illustrates the gap, the mortality gap that exists between people who use mental health services and people who don't. So the average life expectancy is substantially reduced for people who use mental health services, and this represents a health inequality, and it's a health inequality that seems to be getting worse over time. And this very much motivates the programme of research that we deliver here at the University of York. And smoking's been an important aspect of that. And I'll talk about how smoking contributes to this mortality gap over the next few slides. And I have another picture to show you on this graph. This represents the differences in relation to the proportion of people who smoke amongst people who use mental health services and the general population of the United Kingdom. And this shows that the prevalence of smoking in the general population has been coming down year on year over the past 20-30 years. So in 1993, around 25% of the population were smokers, and this has now dipped below 20%. And quite consistently, the proportion of people from the general population who are smokers is fewer than 1 in 5. And the line on the graph above that represents the proportion of people with severe mental ill health who are smokers. And we can see that the prevalence of smoking is around twice as high, sometimes 3 times as high, amongst people who use mental health services than in the general population. And this broader population trend of the reduction in smoking rates year on year isn't reflected amongst people who use mental health services. So people smoke more often, and this is a widening inequality, gets wider each progressive year. So we think that smoking is one of the most important contributors to that mortality gap that we see amongst people who use mental health services. And the final picture in relation to this is an infographic that I pulled from an important report that came out last year from Public Health England, where they looked at some of the drivers for health inequalities amongst people who use mental health services. And you can see those same statistics, more up-to-date statistics, reflected just at the top. So smoking prevalence in the general population is probably around 15% based on last year's statistics, and it's almost 3 times as high amongst people with the most severe forms of mental ill health. But the reason I use this infographic is quite an arresting statistic down at the bottom of this picture. And that shows that about 1/3 of all the cigarettes that are smoked in the United Kingdom are smoked by someone who has a mental health problem. So smoking is a particular problem amongst people who use mental health services. So what are the downstream consequences of smoking for people with the most severe forms of mental ill health? Well, the first thing to note is that the physical health of people who use mental health services, as I pointed out a few minutes ago, is much worse than for the general population. And in particular, in relation to those long-term physical health problems that are particularly associated with smoking. So ischemic heart disease, respiratory illness, and all the smoking-related cancers, much more common amongst people with severe mental ill health. And this contributes to that mortality gap that I've mentioned a few times, and life expectancy is reduced by between 20 and 25 years. And we've spoken about smoking and tobacco consumption being a significant contributor to that, but I also want to highlight here the fact that people who are quite heavy smokers of tobacco, they spend a lot of money on their tobacco habits. So someone who smokes around 20 cigarettes a day will spend between £3,000 and £4,000 per year maintaining their tobacco habit, and this makes it difficult to have any disposable income, and substantially erodes the opportunities for people to spend their finite incomes on other activities that are more conducive to good health. And this contributes to increasing health inequalities. But the final point I would make is that people who use mental health services experience stigma, but smokers in today's society also experience stigma, and this is a consequence of the denormalisation of smoking that we see in the broader population. So people who use mental health services and are also smokers are doubly stigmatised by reason of having a mental health problem, but also being a heavy smoker. So this makes stigma, which is a problem already, much worse amongst people who smoke and use mental health services. So I'll make a very simple point at the beginning of this presentation that smoking is the single most important modifiable risk factor for people with severe mental ill health. So it's with that background in mind, we decided to undertake this trial, the smoking cessation in mental ill health trial, and I'll speak about the design and the results of this trial over the next few slides. But the idea for this trial didn't come from us, but we were very keen to undertake this trial. This is a trial that was commissioned on behalf of the NHS by the NHS Health Technology Assessment Programme. They commissioned this piece of research in around 2008, so just over 10 years ago, and they were very clear in the specification of the design of this trial. They were very keen to find an intervention that might work particularly for people with severe mental ill health. And they talk about designing a trial where the intervention will consist of a bespoke smoking cessation service specifically tailored for the needs of people with severe mental illness. And this is a copy of the commissioning brief that was produced by the Health Technology Assessment Programme all these years ago, and it illustrates what the guiding principles were behind the trial that I'm going to talk about. So the technology is an intervention for people with severe mental ill health, and the setting is in community or inpatient settings, and the control or comparator treatment is referral to standard NHS smoking cessation services. So we've got a direct comparison between bespoke smoking cessation intervention and what happens if you were someone who uses mental health services and decided that you wanted to quit in the NHS or using what are now local authority smoking cessation services. So we thought this was an important question, but the funder of this trial was quite risk averse, and they saw this as quite a complex and challenging trial. And they funded us in the first instance to conduct what we call a pilot trial, where we spent some time developing the intervention and then testing its delivery in the NHS to see if we could make this work, and then to test our ability to actually undertake a trial of this intervention in routine NHS services. And there's a very long report that we produced on the results of this pilot trial that are available for free on the internet, and you can find that on the NIHR library if you were to do a quick search of SCIMITAR and pilot trial. Very long report, and it'll tell you all you need to know about this pilot trial. But I think the point I would make with this next slide is that the SCIMITAR Plus trial, the trial that has just come out in the past couple of weeks, was built on very strong and solid foundations. So we spent some time undertaking systematic reviews to think about what evidence has preceded us to enable us to think about what the optimal content of the intervention might be. So moving from left to right there, they're the results of a systematic review that was published a few years ago by my colleague Dr. Lindsay Banham, and also by myself, and this was published in Addiction, and this is available for free in the public domain, and this has subsequently been updated so you can find systematic reviews of the emerging evidence in this field, and this underpinned the intervention that we use. And in the middle there is an important publication based on some qualitative work that we undertook within our pilot trial that was led by my colleague Dr. Sarah Knowles from the University of Manchester, a very experienced qualitative researcher, where she helped us think about the particular things that we might need to consider if we were to deliver and offer an intervention specifically designed for the needs of people with severe mental ill health. And then finally, over on the right are the results of the pilot trial, the mini-me trial that we conducted in the first instance that was published and is now available in the public domain at the Lancet Psychiatry. And that was published about 4 years ago. And you can download each of those publications for free if you wanted to read some more background on the SCIMITAR Plus trial. So we undertook this trial. It took us a few years to deliver this trial, and we think the preparatory work was necessary and useful because this enabled us to road test the intervention, to learn a little bit about recruitment and randomization and retention, our ability to keep people in the trial, such that when we were able to roll this out in a full trial, we were able to deliver this at scale. And we established some of the important parameters of the full trial, in particular how big the trial needed to be in order to try and answer the question which we set ourselves. And it gave us some preliminary estimates of effects. It made us cautiously optimistic that when we ran a full trial, that it might well deliver a positive result that showed a positive impact of a bespoke smoking cessation intervention for people with severe mental ill health. So that's a little bit about the background to the trial. So what does the intervention look like in the SCIMITAR trial, the intervention that we used at the centre of our research programme? Well, the first thing I would say is that there's been a lot of work gone on in the NHS and in university settings to think about what an intervention might look like to be optimally effective to enable people to quit smoking. And the document which underpins the delivery of evidence-supported smoking cessation interventions right across the NHS and a number of other settings is the Standard Treatment Programme, developed by the National Centre for Smoking Cessation and Training. And people who aren't aware of the resources that are made available by the National Centre for Smoking Cessation and Training should take a look at their website. So it's readily accessible and lots of free to use, free to download resources to tell you a lot more about smoking cessation at that website. I can't recommend that enough. So we use this very important document, this very important intervention, as the starting point for how we might go about helping people with severe mental ill health to give up smoking. But we spent a little bit of time thinking about how we might adapt that to ensure that this works optimally to meet the needs of people with severe mental ill health. So the first thing is that this intervention was delivered by people who had experience of working within mental health services and were trained to very rigorous standards using the NCSCT, the National Centre for Smoking Cessation and Training, second level training programme, a training programme that lasts over 2 days, and it was delivered by people who have these competencies, having attended a course that was in line with these the training programme that's laid out by NCSCT. And at the centre of this intervention are evidence-supported behaviour change techniques. And the medication that we felt that users of mental health services and healthcare professionals would probably feel most comfortable with was standard nicotine replacement therapy. That was the mainstay of treatment. But there were a couple of small adaptations that we made to the treatment programme. And the first was that amongst people who didn't feel confident about setting a quit date, then in the first instance, what we might do, if they felt it was appropriate, we might offer them what we call nicotine preloading, the opportunity to take some nicotine in advance of setting a quit date to try and see the benefits of using nicotine in helping reduce nicotine cravings and hopefully the number of cigarettes that people smoked. And we thought that this might enable them to gain the confidence to set a quit date. Quite a challenging thing to do, to set a quit date. And we thought it just needed a slightly more gentle running than would be the case in standard NHS stop smoking services. And the other adaptation that we made was the fact that if people who use mental health services and were taking powerful psychotropic medication, if they were to successfully give up smoking, then the daily doses that they would require of their psychotropic medication would be potentially reduced. So we spent some time thinking about how we might manage the reductions in medication and how we might work alongside mental health services to ensure that that was done in a planned fashion, and that the changes to medication were appropriately made and adjustments were offered. And we spent some time ensuring that there was plenty of time allocated to plan for a quit attempt, and we encouraged people to think in some detail about what they might do in place of smoking if they were to successfully give up smoking. And we developed a manual, and we also ensured that there was good supervision of people who delivered this intervention. And I'm joined by colleagues who were involved in the development and the delivery of those materials, and they'll be available for any questions that you might have after this session. So SCIMITAR Plus was a pragmatic randomized controlled trial design, and I've got on my next slide a graphic that demonstrates what this trial looked like and how people flowed through it. So this was a very big trial. It's the biggest trial that's ever been undertaken in this area. So we recruited 526 very heavy smokers with severe mental ill health, and the greater proportion of people who entered the trial had received diagnoses of schizophrenia. A smaller proportion of people had bipolar disorder, and there were some other less common diagnoses that had been offered to the people who participated in the trial. And we recruited people from community settings who expressed a desire to cut down or to quit smoking. And we know from research elsewhere that amongst people who use mental health services and are smokers, around 50 to 60% of those people will have an interest in cutting down or quitting smoking. In order to deliver this trial, we needed a high level of collaboration and cooperation with our colleagues in the NHS. So we recruited and worked in conjunction with 21 NHS trusts. So this is a big trial working across a number of different geographies in the United Kingdom. The average age of participants was 47 years. So these were people who'd been using mental health services for quite some time on average, and they had very long smoking history. So the average duration of smoking was 30 years. And as might be expected from people who use mental health services, where we know that being overweight and risk of type 2 diabetes is quite high, the participants in this trial had quite high body mass index, and the average consumption of cigarettes was around 24 per day. So these were quite heavy smokers. And then according to the play of chance, people were either allocated to bespoke smoking cessation, the intervention I've just talked about, or were given advice about how they might access quit services and quit smoking services, either via the NHS or often in the context of local authorities or local pharmacies. So that was usual care. That's what might happen if you were someone who used mental health services and decided you want to quit. So that's the comparison, our bespoke intervention versus usual care. And we followed people up at 6 and at 12 months, and the main outcome of interest was a biologically verified measure of quitting, and this was sustained quitting. So we measured people's exhaled carbon monoxide concentration, where a concentration below 10 parts per million is strongly indicative of someone who hasn't smoked for quite some time. And we also asked them if they had been abstinent for the past 7 days. And there were a number of additional secondary measures that we measured, but the main measure of interest was whether they'd successfully sustained a quit attempt. So the other measures that we used were the Fagerstrom test for nicotine dependence, the motivation to quit questionnaire, some measures of depression and anxiety, the PHQ-9, a measure of depression, and the GAD-7, a measure of anxiety, and a measure of quality of life using the short form 12 instrument. And we also measured body mass index. And we also spent some time asking people and scrutinising their GP records in relation to the medication and the use of health services that they reported. So those were our main outcome measures. And I've just got a quick picture here to show how we managed to recruit to this trial. So this was a big trial and it was a challenging trial, but we had enlisted the help of a number of NHS sites, which meant that we were able to overshoot our recruitment targets. So we recruited more people than we anticipated, and we recruited people more quickly than we had planned to. So we were able to stop this trial a little bit before we had anticipated, and the final numbers were 526 participants. So this is a big trial, and this represents a substantial effort on behalf of the team here and our collaborators at various sites in the NHS. So this slide illustrates who got what, who engaged with which interventions in the experimental arm and the comparator arm. So amongst people who were allocated to the bespoke smoking cessation arm, the greater proportion of people who were offered the intervention actually engaged with the intervention. So 88%, so almost 9 out of 10 people offered the intervention actually engaged with it in some form or other. And the median number of sessions that people attended were around 6. So the greater proportion of people engaged with it and got quite a few sessions. And the average duration of sessions was around 34 minutes, lasted about half an hour. And the majority of these sessions were delivered in a face-to-face context. So the smoking cessation advisor that we trained met up with the person with severe mental ill health to help them think about a quit attempt and then to support them once they'd made their quit attempt. And the mainstay of treatment, as we'd anticipated, was nicotine replacement. But towards the end of the trial, e-cigarettes became more popular. And we saw that because a third of the participants, particularly the later participants recruited to the trial, reported using e-cigarettes as a means of receiving some nicotine replacement, nicotine support. And a very, very small proportion of people used Champix, varenicline, which is a medication that's commonly used to support quit attempts. It's commonly used in the general population, but there's some level of caution in relation to the use of that amongst people who use mental health services. So if I were to compare this good level of engagement with the bespoke smoking cessation intervention with what happened in usual care, well, there was very minimal engagement with standard NHS or local authority stop smoking services. The level of engagement was very, very low. And this supported what we anticipated in advance, and this is one of the reasons the trial was commissioned, and that's because people with severe mental ill health don't readily engage with standard smoking cessation services. A significant proportion, around a third of the people who received usual care, made their own purchase of nicotine replacement using over-the-counter OTC. And so people were buying their own supplies of nicotine replacement. And we know that people often use those nicotine supplies suboptimally. And that the smoking cessation advisor, one of the key roles was to optimize the use of nicotine replacement. And that's one of the reasons we saw a better use of nicotine replacement amongst people who received the intervention. A similar proportion, just a little over a third of the participants also used e-cigarettes in the usual care arm, and a very, very small proportion used varenicline. So this was some substantial differences that we saw in terms of engagement with the intervention. So this made us feel as though people like this intervention. This is something that they wanted to use. So that's really interesting. But the main thing you'd want to know about will be the results of this trial. So I'm now going to talk about the main primary outcome measure, this sustained quit attempt, and how this was evident at 6 months and at 12 months. So, so the next picture illustrates what we saw at 6 months and at 12 months. So the main difference between the groups was revealed at 6 months, and this had become attenuated to some extent at 12 months. So at 6 months, people had only relatively recently ceased to engage with their smoking cessation intervention, and we can see that there's a substantial difference in the proportion of people who successfully made a quit attempt and were noted to be abstinent at that point using this carbon monoxide verified quit attempt. So just under 15%, 14.2% of our intervention group had managed to successfully quit, compared to 6.5% in the usual care group. And this was statistically significant using the planned statistical test that we put in place before we started this trial. When we got to 12 months, there was still some difference between the groups, but this had just ceased to be statistically significant. So we can't be confident at that point that there was a difference using these conventional tests. So we've got some clear difference at 6 months, and we can be a little bit less sure of that at 12 months. So we were concerned that this demonstrated that there was no difference between the groups, but I want to caution you against making that assumption. So I've talked about SCIMITAR Plus being a very large trial, and it was by some measure the largest ever trial that's been undertaken in this area. But we were still what statisticians call underpowered to detect a difference at 12 months. And that's because the baseline quit rates were much lower than we'd anticipated in our pilot trial when we got to 12 months. So we did some calculations afterwards, and we found that we didn't have the statistical power to perhaps detect a difference if one were evident. And the next slide, I think in a slightly humorous way, illustrates what we were concerned about. And we are concerned that we might have made a type 2 error in this instance. We might have failed to detect something that was there. We might have failed to detect a difference even if one was present. So we are concerned that this lack of statistical significance between the groups might obscure a real difference that was there. And the explanation for that is that we didn't have quite enough participants in the trial to demonstrate a difference. So I'm going to present what happens when we try to bring back some statistical power to this data set. And what we did afterwards was we combined the results of the full trial and the pilot trial to increase the sample size by which we seek to answer this question. So what we've done there is we've reconciled the results of the pilot and the full trial. So I've illustrated that by putting on the left the results of the pilot trial and on the right the results of the full trial, which were published in Lancet Psychiatry again just a couple of weeks ago. So the next picture represents what happens when we undertake a meta-analysis, a synthesis of the data between the pilot and full trial at this 12-month follow-up point. So we are able to answer this question with a greater level of statistical power to generate a greater level of statistical precision. So there's a picture, a forest plot representing a meta-analysis of the pilot and full trial data. And these slides will be available afterwards, but I think this illustrates that when you bring some additional statistical power, we can be confident that at 12 months there is a significant statistical difference between the intervention and the control groups. And this makes us confident that there is a difference both at 6 months and at 12 months. So SCIMITAR was positive in its primary outcome when we pooled across both trials, both at 6 months and at 12 months. Okay, so if you cast your mind back a few slides, I pointed out that we'd also measured what we call some secondary outcomes, and we saw that there was a reduction in the terms of the number of cigarettes that were consumed between the two groups. So people who received the bespoke intervention, there was a reduction in the overall number of cigarettes amongst that group. And we also noticed some short-term improvements in terms of physical health as measured by the short form instrument. And we also noticed that there were no differences between the groups in terms of depression or anxiety. So one of the concerns that people who use mental health services or people who work in mental health services sometimes express is that quitting smoking might potentially be bad for your mental health. Well, we didn't notice that in this trial. And in fact, we know from research elsewhere that successfully quitting smoking is actually good for your mental health. It reduces the levels of depression or anxiety. But we did notice that there was a small amount of weight gained amongst people who successfully quit smoking. So, and we anticipated that, which is why we measured it. So this is a thing that we know generally, any smoker, irrespective of whether they've got mental ill health, if they were successfully to quit smoking, they put on a small amount of weight in the first 6 to 12 months, and that usually drops off at a point of follow-up. So we don't know whether that was the case, but we did notice what we anticipated would be this small gain in weight. So I've got a brief slide that speaks to not the clinical effectiveness, but the cost effectiveness of the SCIMITAR Plus programme, whether this represented good value for money. So we had some very clever health economists work with us on this trial who helped us understand whether the investment in a bespoke smoking cessation service might result in improved health outcomes and acceptable ratio of benefit to cost. So what we looked at was the short run cost effectiveness, what the differences in cost and effect were during this relatively brief 1 year time horizon within the trial, bearing in mind that the cost effectiveness of smoking cessation interventions is often realised several years down the line when people experience health benefits and the frequency of long-term physical health problems is reduced amongst people who successfully quit smoking. So we noted that there were some additional costs of the delivery of this bespoke smoking cessation intervention in terms of the training of our practitioners and the extra time involved in the delivery of this intervention and the prescription of medication and the offer of supervision. But we also noted that there were very few costs in the usual care arm because very few people accessed standard stop smoking services. So when we did the calculations, we can be more confident than not that the trial resulted in a reduced overall costs and a greater level of effectiveness. So this was potentially a cost-effective intervention. But in order to be certain about this, we probably have to follow people up on the longer term because the benefits of quitting are likely to be achieved across the lifetime. We've not measured this yet, but we are going to model that in coming years. But we do know that smoking cessation from cost-effectiveness analyses elsewhere that have been conducted by colleagues here in the University of York and in other settings always demonstrate that a smoking cessation intervention is one of the best investments for the NHS in terms of return on investment. So that's probably the end of my presentation of the results of the SCIMITAR trial. I've just very briefly got some reflections. Now, this was a question that was posed by the NHS around 10 years ago. And I feel that we've addressed this question and we produced what is a very big trial, and it's got results that we feel are generalisable across the NHS. We achieved some very good long-term follow-up, so we can't be concerned that the results of this trial are in some way the result of very low levels and follow-up and sources of bias. And we've developed a feasible model which aligns quite nicely with the National Centre for Smoking Cessation and Training protocol and programme of treatment. And so one of the things that we're going to do is work with our colleagues at the NCSCT to think about how the materials might be adapted and made available in the public domain. And this was a challenging trial, so we're keen to keep working in this area. We've not answered all the questions in this area, but we have generated a lot of goodwill and a very effective network for researching in this space. And we've got the capacity to deliver future research in this area. So that was what we think went well with this trial. But we think there were things that we might have done better if we were starting again. So one of the concerns that we had was that the medication supply for people in the trial, there were several links in the chain, and that meant that for some people it was difficult to ensure that the medication that they decided to take was made available to them. So they had to go back to their GP to get a prescription, or they had to work with local services to ensure that they got their nicotine replacement, and that was challenging for some people. So we think if we were to implement this research, it's really important that there's a one-stop shop to ensure that the delivery of the intervention happens alongside effective provision of pharmacotherapy, things like nicotine replacement therapy. We think that varenicline, Champix, a very effective medication, a very safe medication, was underprescribed in this trial. And we know from trials elsewhere that this is the most effective medication that can be used to support a successful quit attempt. And E-cigarettes weren't on the scene when we designed this trial, and we saw that quite a few people within the trial decided to use e-cigarettes. And if we were to implement this, I think it's really important that the delivery of it encompasses the safe and supportive use of e-cigarettes, if that's what the person wants to do. And I've also highlighted that the people in the trial had often been using mental health services for quite a long period of time. We think the assumption that you can immediately translate this to younger people, often with their first contact with services, it might need a little bit more thought about how we might use this intervention for that population. That wouldn't stop us offering this intervention for that population, but we think there's perhaps a little bit more research that we'd want to do, and that's going to be an active area that we're going to progress over coming years, thinking about how we can best ensure the delivery and engagement with people at their first point of contact with NHS mental health services. And despite our best efforts, and despite this being the biggest trial that had ever been conducted in this area, we had less statistical power than we set out to achieve. And we've tried to remedy that by bringing together results of the pilot trial and the full trial. And it does make us confident that the intervention is effective in the short and in the longer term. But if we were to do this again, we probably need to do an even bigger trial. So it's quite a challenge. And I think I've hinted at how much effort went into the delivery of this trial for over 500 participants. Okay, so those are the results of the trial. And we think the results of this trial are quite timely because these align quite nicely with one of the priorities that's been identified very recently in the NHS long-term plan. And the NHS long-term plan, I've pulled out a quote there from the NHS long-term plan. It highlights the importance of the provision of smoking cessation services and a bespoke smoking cessation service for the people who've been left behind in the general reduction in smoking prevalence in the general population, to try and reduce the disparity that exists between people with and without mental ill health. And we think we've got a feasible intervention that could enable the realisation of this very welcome aspiration across the NHS. I've not got many more slides now, but two more. So I'm just going to summarise what I think I've talked about. So people with severe mental ill health have some of the highest rates of smoking amongst any section of the population. And the majority of those smokers actually want to cut down and to quit smoking, but they don't access and haven't benefited from conventional stop smoking services. So what we did was we developed an intervention, and we've tested this in the SCIMITAR trial. And the intervention is a specialist intervention to try and maximise the chances of people with severe mental ill health who want to quit to successfully quit. And the results show us that there's a very good engagement with this bespoke intervention, and that there are statistically reliable, verified improvements in quit rates in the medium and in the longer term. And we think this is a timely, evidence-supported model for service provision. So the final slide, I think, represents how the ripples are going to move out in the pond with this. So we're working alongside a series of valued colleagues to think about how we can move the results from the hallowed pages of academic journals into something that influences practice and policy. So the first thing is that we published this in the Lancet Psychiatry. So this was published in the paper version of the Lancet Psychiatry 2 weeks ago and online about a month ago. And we've ensured that this is an open access publication. So if you're interested in the results that I've just talked about, you can download the full results of this trial onto your computer and read them at your leisure. You don't need to have paid for a subscription to the Lancet Psychiatry to read about the SCIMITAR Plus trial. The other people that we're working with are the super people at ASH, and so we're benefiting from that in this webinar today. So we're grateful for the support that we've received from ASH, and we're going to continue to work with ASH over the coming months and years to ensure that the results of this trial are used to inform practice and policy. And in coming months, we're also going to work with our colleagues at the National Centre for Smoking Cessation and Training. They were very helpful for us at the beginning of this trial to help us think about the design of the intervention, and we are keen to close the loop and to work with colleagues at the NCSCT to ensure that the results of this trial and the materials that we use in this trial are adapted and made readily available to people who design and deliver smoking cessation services in the NHS or other settings where smoking cessation services are offered. offered. And we're also grateful for the support that we receive from our funder, and in time there will be a very much longer report of the results of this trial available through the NIHR library. So that will be a long publication, probably about 250 pages, and it's the sort of thing you might want to read if you're a chronic insomniac, or if you want to find out more detail than we were able to provide in the Lancet Psychiatry publication. So that's nearly it from me. I just want to thank lots and lots of people, not least of which the people who were smokers and used mental health services who wanted to work with us in this trial and made a leap of faith in signing up to this trial and helping to deliver really important results that we think are going to be informative for other people in the NHS and people who work in the NHS, and for people who plan and deliver services. And I'm also grateful to all the super colleagues who worked in those 21 NHS trusts and some of our partner universities. And I'm also grateful to the people I've got here in the room who enabled us to deliver this trial. So I'll spare their blushes, and I will stop talking at that point, and thank you very much for listening.
Thanks very much, Simon. That was a really interesting presentation. I'm sure it's given a lot of people on the line a lot of interesting stuff to ponder. I think that the screen should be switching back to mine now, which has a reminder of how people ask questions. We've had 4 or 5 questions through so far, which I'll put to the panel shortly, but I think we've probably got time for maybe 2 or 3 more. So if you have any last minute questions, do please send them through. So I will kick off. I will welcome Suzanne and Emily to the room. Are you both able to say hello?
Hello.
Hi, this is Emily.
Hi, thank you. So great. We've got a number of questions too, as I mentioned. They kind of fall into 2 categories. One is kind of technical questions about how the study was working, which I'll start with, and then there's some kind of broader, more strategic questions, which I'll get onto afterwards. So to start with on the technical questions, one is, did you also measure participants' use of other substances, I assume alcohol or illegal drugs? And do you think this had any influence on outcomes for the population?
Yeah, this is Emily speaking. We did measure participants' consumption of alcohol. We asked them how much alcohol they consumed in the baseline questionnaire and at the 6 and 12-month follow-ups. And we also asked participants whether they used any recreational drugs, in particular with reference to replacing smoking with the use of recreational drugs. And although we haven't done any analysis of those things, I don't think there was any real differences that we noticed.
Good stuff, thank you. And on to the next one. So one of the listeners has said that she's a little puzzled why 31% of patients purchase their own NRT in the usual care arm. In her experience, NHS specialist services find it very difficult to get smokers to purchase their own NRT. Was that something that you encountered on the trial?
Yeah, I'll briefly speak to that, and then if Emily and Suzanne have got any additional comments. So the first thing is that there was only a very small proportion of people who have been signposted to standard stop smoking services in the NHS or local authorities actually engaged with those services. So we're starting from a very low baseline, and again, this reflects the broader concern that we have that people who use mental health services historically don't engage with non-specialist NHS or local authority quit smoking services. So it's only a small proportion. I don't have the figures to hand, but it was really, really tiny. So amongst those, some will have received things like nicotine replacement therapy, but we felt that around a third of the participants were probably purchasing their own over-the-counter medication as a way of engaging in a self-directed quit attempt. And we know from research elsewhere that those are generally pretty unsuccessful.
Yeah, and we also found that people, when they were trying to access smoking services, found it quite difficult, and the services were quite difficult to navigate and to know where to go to get the help. So I think that's also what resulted in people purchasing their own NRT, sort of giving up with trying to navigate the services. Although everyone was in usual care was signposted to where to go to the services weren't all that easy to access. And we have written a paper which we hope will shortly be published on what constituted usual care in the different areas where we recruited patients, and that's one of the things we highlight was the difficulty in actually navigating the services once people were signposted to them.
And was that difficulty kind of seen across all of the usual care settings, or were there some areas that did it particularly well, or some where it was particularly difficult?
I can't remember, by area, but in some areas it was definitely easier to navigate than in other areas. And it seemed to be where areas had had the services cut, or where services had been subcontracted out to third-party sectors, then it was more difficult for people when they were no longer under the NHS to find where to go. Great,
that's really helpful, thanks. We've just had I just had another question here. We said, you spoke a bit about the use of e-cigarettes in the trial and how kind of it wasn't designed with them in mind. Do you feel like the results would have been improved if e-cigarettes had been built in from the start?
Difficult to know. We can't second guess the answer to that. There is research evidence emerging about the use of e-cigarettes to support successful quit attempts. So a trial came out last year that generated quite a lot of publicity and lots of interest. So we would take quite a pragmatic view that it's really important that people receive some form of pharmacological support to reduce their level of nicotine withdrawal. And we know that nicotine replacement by patches or by gums or by lozenges is very effective in reducing the levels of nicotine withdrawal. And we would see e-cigarettes as just an alternative means by which people could receive nicotine to minimise their experience of nicotine withdrawal. And lots of people tell us, and lots of people have told other people, that they find e-cigarettes quite an acceptable and potentially quite enjoyable way of getting a nicotine replacement. So we'd go with what people's preferences were. So towards the end of the trial, e-cigarettes had become more popular, and we just followed the helpful guidance that's been offered by the National Centre for Smoking Cessation Training in this respect. And they always encourage any form of quit smoking service to embrace rather than reject people who want to use e-cigarettes, and to supplement the use of e-cigarettes with the behaviour change techniques and the behavioural interventions that they know are really effective in helping people to successfully quit. So we think e-cigarettes form a part. As to whether, and the question was about this, whether it would be more effective, I don't really know the answer to that, but we know from research elsewhere that nicotine replacement via e-cigarettes is potentially effective.
Grand, very helpful. In terms of a more kind of strategic question, somebody's asked whether you're able to share which NHS trusts were involved, and kind of for some advice about how to kind of encourage NHS colleagues to champion the level of support that you guys were able to offer.
Yeah. So, we can, if you were to take a look at the full report, that'll have a very comprehensive list of all the individual NHS trusts that were involved in this trial. So we'd like to think that we've left a footprint, and they have some memory of the trial such that this might inform the implementation of this research in their locality. So that's up to individual sites. And if you work in one of the sites where SCIMITAR ran, then that might be useful for you to contact the person in your local trust to maybe learn a bit more about SCIMITAR and how it works in that organisation. If sites were interested in implementing the results of the SCIMITAR trial, then by all means look at the NCSCT website. Some great materials on there, read the papers, but in time we hope to make the manuals that we use to support these interventions more readily available through NCSCT, and we're in some negotiation with colleagues just at the moment, so we hope to have more to say about that in the future. I'll stop talking at that point. I think Emily might have something to add.
Yeah, so we've been working with our colleagues at the NCSCT, and we're hoping that probably it's going to take a bit of time to get it there, but hopefully in the next year to have an online module that people will be able to undertake.
Yeah, and I've got to say it's really exciting for us to hear that there is interest amongst colleagues working in the NHS about how this intervention might be more broadly implemented, because this has really been an afterthought in lots of mental health services just at the moment, and we think this has got a potential to make quite a substantial difference in improving the quality of services that are offered to people who use mental health services to ensure that people with mental ill health who are heavy smokers and want to quit are actually optimally supported in those quit attempts, if that's something they want to do.
And another thing to say is we're going to be running, I think it's on, I can't remember the exact date, but it's in June. If people want to get in contact, we can let them know the exact date. We're running a smoking cessation in severe mental health workshop that people may want to attend to learn more about the exact details of what the intervention consisted of and how they might want to utilise it themselves.
Fantastic. That's really helpful. Thank you. We just had a really interesting question in from a colleague at a Stop Smoking service who says, from their point of view, some of the difficulties they face are getting referrals from mental health professionals. And the question they wanted to ask was whether kind of you encountered the the experience that many of us have heard in the past, where mental health professionals are worried about supporting their clients to quit smoking because they're worried that their mental health will decline, or that the path to doing so will make kind of supporting them harder. Did you guys encounter that, and if so, were you able to overcome it?
Yeah, I mean, there's two elements to that. I mean, the SCIMITAR trial, was a big trial, so it reflects the fact that there's perhaps more enthusiasm than we'd anticipated amongst colleagues in NHS services, because they were keen to run with this trial. Lots of enthusiasm amongst people who use services to find out more about smoking cessation, because they entered into this trial as well. So it's not all bad news, but because we work in this area, we speak to NHS colleagues, and many of us have worked in the NHS for a long time as well. So we're very much aware of the general reluctance and caution and anxiety around offering smoking cessation to people who use mental health services, amongst people who work in mental health services. So this notion that nothing works, or it might be detrimental to people's mental health if they were to give to quit smoking, is something that's quite pervasive. It's a widely held belief in the NHS, but that not amongst everyone. And we're hoping that the results of the SCIMITAR trial will be useful in trying to give people some belief that something does work. So the results of the SCIMITAR trial are positive, and also that people can successfully quit smoking without it being detrimental to their mental health. So we're hoping that SCIMITAR is part of the story in trying to address this sort of broader institutional and individual reluctance to engage with smoking cessation amongst people who work in mental health services. So it's a great question. We'd like to see more referrals from mental health services, and but that's one for policymakers, really. If people want to make quit smoking services in their mental health trust a priority, that's a priority that needs to be made by individual trusts in terms of the policies that are laid out and the priorities that are identified at a board level.
Thank you. Yeah, I agree with you. I think the kind of the comms potential for these findings are really, really, really interesting and important, and I think that will be one of the great things that comes out of the trial. I had a similar question about the use of varenicline, which I know. So we know that previously there was a warning attached to varenicline for people with mental health problems, and somebody's written to say that when they prescribe it, people who are using it often experience crazy dreams and things like that. Did you encounter any adverse reactions to varenicline on the trial, or did it kind of did it all go as expected?
Well, there are two elements to that. So the first is that there was so few people in the trial that used varenicline that I don't think we can use this trial as evidence that varenicline is the best form of intervention. So the results of the SCIMITAR don't support the use of varenicline. But we do know from research elsewhere, so this is quite a rapidly evolving area. So there are two things. So people have been concerned about the safety and side effects of varenicline for a number of years, to the point that there are some cautions either in the BNF or in prescribing guidelines in the United States. But since they were first issued, there's quite a lot of randomized evidence that's emerged that demonstrates both the effectiveness of varenicline and the safety profile of varenicline. So we published systematic reviews that amalgamate all the trial-based evidence in this area, and there's some quite substantial trials that show that varenicline is just as safe and just as effective amongst people who use mental health services as it is in the broader population. So I would make the general point that it's underutilised amongst people who use mental health services. And I'd be quite happy for varenicline to be used alongside evidence-supported behaviour change techniques for people who use mental health services, just as it is for people who access quit smoking services in the general population. So we think varenicline is safe and effective, and we make that assertion based on systematic reviews that we've published just in the last couple of years.
Great, thank you. Thanks everybody, by the way, for all the questions. They're streaming in now. I think unfortunately we won't have a chance to answer them all. We will get back to you on the outstanding ones via email. I think we could probably squeeze in 2 more if nobody has to immediately go at past. So the first one is, did you see a reduction in mental health meds prescribing for those who had quit smoking?
I don't think we did, no. I probably have to ask our statistician colleague. So we probably didn't have quite enough people who had quit smoking to enable us to confidently say that there was no difference. But I think that anticipated difference and reduction in prescribing might take might have taken a bigger trial to demonstrate that. So we probably didn't have sufficient power. But we can think of individual examples where people quit smoking and then went and had a discussion with their mental health team about the dosage of for example, antipsychotic medications that they were receiving, and the very clear prescribing guidelines that suggest that you should reduce your dosage of medication if you are someone who's been a heavy smoker who then successfully quit smoking. So we had some individual examples of that, but we didn't notice that on average within the trial, but it might have been that the proportion of smokers was sort of diluted by the overall effect we saw in the trial.
Great, thank you. And the last one is, maybe this will be something for everybody on the panel to let us know their thoughts on. It's like, what's the next steps in this journey? Like, what should people do next if they want to get involved, or and what are you guys planning on doing next?
Well, 2 things. Well, we want to ensure that the results of this trial don't languish on the pages of an academic journal. So we want to ensure that this knowledge is translated into practice and to policy, because we think this is research that's relevant for the NHS, because we know that because it was commissioned by the NHS. So we want to ensure that the results of this trial are made more widely available. And I'd hinted at some of the ways in which we might do that. So we want some materials to enable people to deliver this intervention placed in the public domain. But there are a few people who didn't get into our trial, so we think there's more research to be done in 2 particular areas. So we're really keen to find out how best we engage younger people with their first experience of mental ill health, their first contact with mental health services, where they're at particular risk of becoming a lifelong heavy smoker. So we think the opportunity for early intervention to optimise their health and enable younger people to make healthier choices is really important. So we'd like to do more research in that area, and we plan to do that over the next 12 months. And the other area that we're particularly interested in is people who didn't make it into this trial, with people who we either currently in inpatient mental health services or have recently been discharged from inpatient mental health services. And we think there is a group of people who potentially might have a different set of needs, and we might need slightly different approaches to engage them with a smoking cessation intervention. And we didn't include those people in the trial, so we'd be keen to do more research in that area. And the third thing is we're really keen to find out what the longer term impact of SCIMITAR is. So we're going to continue following up the participants in the SCIMITAR trial in the longer term to find out what the long term impact is in terms of successful quitting, but also what the longer term benefits might be for people who successfully quit in terms of improvements in their physical health and improvements in their financial status. So those are the 3 areas we want to go.
And we're also hoping to use the data that we've got from SCIMITAR, because we've got quite a lot of data, and we know the use of e-cigarettes in this area, there's not a great deal of evidence or information about it. So we're looking to do some additional analysis around the people who did use e-cigarettes and the people who didn't, to see if there's anything we can find out from the information we've gathered from SCIMITAR, and also from a wider cohort of people that we've got, where we've asked them a little bit about their e-cigarette use, to try and just understand a bit more about e-cigarettes and people with severe mental illness.
Anything from Suzanne?
I think just with regards to rolling the what we've learnt out to various trusts to be able for them to incorporate it into each trust, so that everybody is aware of what's available, and potentially introduce it to inpatient healthcare settings, which is where it's really difficult for people to continue to smoke, so that they've got the options available to them there.
That's fantastic. Thank you very much. Sorry, it's about to cut us off in about 1 minute, so I just want to say thank you all very much for the really interesting info that you've shared with everybody. We've got a bunch of extra questions which we'll answer afterwards. We'll also send a link round of the recording so that people can direct their colleagues to it if they think they find it interesting. And if you have any additional questions, please do drop us an email. At the email address that we got in contact with you for the webinar link, and we will do our very best to answer it. So thank you very much, everybody.
Thanks, Ciaran.
Thank you.
Thanks, everyone.
Thank you.
Bye-bye.
Bye-bye.
Thanks. Bye.